So I'm going to have introduce Eric Offerdahl, who is here with us from Freight Art South in Pleasant Prairie, and he's going to share a case study with us today.
So I'll preface this with this person was in 3 different hospital systems, so it was a little tricky to track her through her extended treatment that she had. So we had a 49-year-old woman who came through an outside hospital. It was transferred to us, came in through their ER, and they were transferred to us because we could provide better care to her. She just appeared with weakness, headaches, mid-grade fever, feeling cold shivering, hallucinations, and confusion. So nothing really that pointed out what it was exactly at first. Her history, she had underwent posterior fossa decompression for a Chiari malformation. It's effectively her brain. That's a structural defect where her brain was protruding through the opening in the bottom of her skull into the spinal cord canal. And the decompression surgery, I didn't really get the details of it, but effectively just opened that natural opening up a little bit to just relieve some of the pressure. And that was really the only indication she had of what this could be leading back to. So they did the procedure normal enough, sent her home after a couple of weeks, sent her home under, what was it? That she represented Ben then about a month later or so in June with just a severe headache was her only complaint. So they sent her home with this Fiore set that's an acetaminophen, a caffeine to boost the acetaminophen effects, and then a barbiturate that was just a sedative to help her, help her sleep and such. Other than the headache that she reported in the June admission, there was nothing out of the ordinary in her history between when she was discharged from the procedure and when she presented to us in July. Other than that, just a quick overview. She had a pretty extensive medical history, but these are kind of the highlights, if you will. Nothing that really stood out, but just kind of general. She had COPD. She did have a history of half a pack a day smoker for 20 years, but she had quit back in 2020, so there was still some lingering effects, I'm sure, from that, but nothing actively ongoing, but nothing that really pointed out what was causing the weakness, fever, headaches, and such. So came in, unremarkable blood work to speak of. They did an LP to rule out meningitis. Brief summary of the results, obviously with the protein being sky high, glucose low, nucleated cell count up, clearly looks like some kind of meningitis or encephalopathy or encephalitis or something. So at this point, it really doesn't point to anything, but any guesses as to a causative agent? Something that would get your attention and go, oh, what?
All right, everyone, help him out. So what are we thinking this could be? Anybody just shout it out. Got any ideas what you might be looking at?
No. That would have been far, far too easy. That wouldn't have even, unless it was a really odd bacteria, that wouldn't have even gotten our attention.
Anything else?
It's something you see probably pretty frequently, but just not from this kind of presentation. So I can't compete with Stephanie's puns, but it was Candida albicans, of all things. So, again, they did a whole shotgun pattern of testing for it. The cryptococcal antigen came back negative, though we have seen some of that in clinical samples by us, but nothing from a spinal fluid source. They did the HSV to screen out a viral cause, but both for viral and bacterial cultures grew the Candida albicans. ID'd by our Malditoff in-house. We did have to send out for susceptibility testing, I believe, to WDL, and it came back as pan-susceptible to everything that they tested for, at least. So they treated her with the fluconazole and amphotericin B, both common enough. She initially was started with acyclovir to cover a viral cause before the cultures grew anything, because the cultures, for whatever reason, it was slow growing for us. I think it showed up on day 3, I want to say. And then we had to send it up for testing, for the susceptibility testing and that. So they did note some minor hydrocephaly and threw in the furosemide just to, as the diuretic to help treat the little bit of fluid build that they were noticing. They kept on going with the Fioricet and additional acetaminophen just to keep the headaches and the evident symptoms down for a time. 1 week later from admission, they went back, did another LP. Protein is still high, it was a 124, now it's up to almost 200. Glucose remained about the same, it was 22 initially, it still took it up down to 24. The cell count was normalizing a little bit. It was down from 1205 for the nucleated cells down to 703, but it was still, as far as the neutrophil percent inside, it was still pretty high considering. They did place a shunt to help drain the excess fluid from the hydrocephaly. A week later, after that follow-up LP, the patient was transferred out to a third hospital system. I forget which one, but they continued with the amphotericin, added another drug called flucytosine. That's just an antifungal drug that's specific for treating severe candidal infections. They did ongoing spinal fluid collections. The cultures never grew anything after the one that was collected on the 10th, I believe. But as you can see here, her values all remained kind of steady. That last one was clearly a traumatic LP from the 26,000 in red cells, but everything else seemed to start to normalize, but I want to say she's just recently recovered from this completely. I didn't have room on the chart, but they did continue to do acridine orange stains ongoing, that every one of them came back negative for what that was worth. Finally, on August 1st, she was discharged from the hospital that she was transferred from us to with instructions for just home. I think she did outpatient PT, as well as continued the antifungal IV treatments through a PICC line that she had installed before she was discharged. Came back 4 days later with severe nausea, headaches, vomiting, unable to keep food or some of her meds down, any of the oral meds that she was taking. The only thing that was noteworthy was she has a potassium that was down, I believe, as low as 2.2 at some point, that they treated with IV meds with potassium supplementation and sent her home, I believe, later that day or the next day. She came back then on the 11th, I forgot to put this in the presentation, came back on the 11th and ended up with the pan-sensitive E. coli and Klebpneumo UTIs after all this. No urine culture was done after that one on the 11th, but I checked in with her a couple days ago, and she was still had ongoing issues for some reason with the UTIs, but it seemed like the candida meningitis had cleared up. Interestingly enough, I looked back in the surgery notes from the original decompression surgery. There was one swab collected from the incision site that grew staph epi and that Candida albicans. So I looked through the chart, it was difficult again since she passed through so many different systems. There didn't seem to be an official word on where the albicans came from, but make your own implications there. So my attempt at the wordplay was, what other dastardly deeds will this fiendish fungus fulfill? So that was it.
Thank you. Any questions? Have other people seen a lot of or any presentations like this? Anyone else seen something?
I mean, I've been in the field for, I think, 15 years or so, and it's the first time I've seen a yeast meningitis personally, but yeah.
Fascinating case. Thank you so much for sharing. I'm not very familiar with the surgical procedures for a Chiari malformation decompression. Is this, I'm guessing by the staph epi and Candida albicans, come from the outside, or do they go through the throat?
And I had to look it up. I believe they go in through the back of the neck.
Okay.
And it's just a relatively small incision. I don't know if they go in robotically or what. I didn't really look into the surgical procedure that much, but I had to, like you, I was unfamiliar with it. I had to do some research just to describe what all happened.
Yeah, very fascinating. Thank you so much.
Yeah, of course.
So now you can see it's easy, and next year we're going to have 5 volunteers, right? Thank you so much, Eric. I appreciate it. It was a great story.
Hi, everyone. My name is Mark. I'm one of the pathology residents at UW Health.
And I'm Kelly. I'm the supervisor of the micro lab.
Okay. So I guess we'll just get into it. So our clinical case, so I'll be presenting the clinical part of the case, and then Kelly will take over. This was a case revolving around a 63-year-old male who really otherwise didn't have past medical history, significant for anything, except for hypertension that he hadn't even seen a doctor for any time recently prior to encountering us. But the story really starts 3 months prior to when he came to our attention. He presented with like a progressive shortness of breath, a dry cough, and shortness of breath while lying down. And he was actually diagnosed with COVID-19, but it was unclear if this was something he was hospitalized for. I believe there was a prescription for Paxlovid. It was unclear if this is something he actually took home with him. It can be prescribed over the phone, I think, but you don't need to take it home, or you don't need to fill it necessarily. Around that same time, the patient had visited Laos with his wife for a funeral of a family member, and they stayed 3 weeks. So this is kind of something that he presented with right after coming back to the United States. He did have a brief encounter with listeria in the form of meningoencephalitis, and this was documented in the chart, this chronic eosinophilia, but it was unclear if there was a specific cause of this. And the reason I say that is because I purposely made the slide busy because there's so many causes of eosinophilia. It could be due to simple allergy, it could be due to problems with autoimmune disease, certain cancers cause eosinophilia, and then of course certain infectious diseases. And so it wasn't clear if that's something that he was currently dealing with at the time where he was diagnosed with COVID, or if they even found a reason for it. To my understanding, he just had chronic eosinophilia in the blood. And this is not a chest x-ray from him, but we're going to see a chest x-ray from him. And I am by no means a radiologist, but I thought we'd take a look at something that you don't necessarily see if you just read the report in the patient chart. This is actually a normal chest x-ray, and there's a bunch of landmarks I could never pretend to understand why or how they present on film. But this diagram highlights some of the landmarks you might be looking for when you're looking at a chest x-ray. And the one I wanted to focus on is the contours that show on x-ray that represent transition from diaphragm to your air-filled lung in a normal scenario. And the reason being, when there's pneumonia, this contour can be obscured, so to speak. And this is, so if this is a normal x-ray, this is actually the x-ray from someone with a very advanced and fulminant COVID lung. This wasn't from our patient. We don't even know if this patient was admitted with COVID pneumonia. But you can see that not only is the diaphragm contours obscured, the actual like air-spaced cavities in the lung as well are filled. And that can be caused by a variety of things, not COVID, but the point is it's usually something that's not good and quite severe. And just for contrast, to describe to you how sometimes difficult it can be, especially if you're not a radiologist, this is actually the chest x-ray on the left is of him 2 months after this initial presentation, and the residual pneumonia, if it was even there, is at the bottom diaphragm contour. It's a little bit obscured, and that can happen. So the patient might not even be symptomatic, and is just a residual effect of the pneumonia. And then on the right is a normal chest x-ray for comparison. So something we overlook on the report, but something I thought I'd show just to provide some context. But going back to the story, it's like I said, the pneumonia was obviously resolved, and it's unclear if the patient took Paxlovid, but it was prescribed. I think about a month prior to our encounter with him, he presents to Meriter Hospital close by, where a CT scan shows a pericardial and a bilateral pleural effusion. So at this point, this patient has a pathologic fluid around the heart and the lining of the lungs. No cultures were positive at this time in and around this hospitalization. The patient was hospitalized to evaluate for this. And part of the hospitalization at this point, especially given the travel history, the doctors or the infectious disease docs were concerned for tuberculosis. However, his quantiferon results were indeterminate. And so just to kind of backtrack and familiarize yourself with the timeline again. So he has a COVID-19 plus pneumonia, unclear if it's due to COVID in April, hospitalization in May, and then around June is when we encounter him for the first time at UW Health, and he returns with a cough and shortness of breath that continued to get worse. So it's unclear if these are three things that were unrelated, or if this was just something that was lingering and continued to get worse, or just continued to kind of stay in the background and not get resolved. At this point, as opposed to the two prior encounters before coming here, he did have swollen lymph nodes, and then the fluid around his lung, though it initially got better, came back worsened. So he had worsening pleural effusions. I think this is where you take over?
This is where I go?
Okay.
All right, yes. So now we will start with some of the lab values, and we'll see if we can figure out what this pathogen is. So throughout outpatient as well as inpatient time with us at UW Health, this patient had a variety of CBCs with differentials done and consistently had elevated white blood cells, including elevated neutrophils and eosinophils. So then on May 8th, a sinus culture was performed, and that grew Staph aureus as a pathogen, as well as some endogenous flora. May 26th, blood cultures were drawn. Those were negative upon full incubation. May 27th, we received a pericardial fluid. So the bacterial culture grew Cutibacterium acnes, and just for reference, we incubate our bacterial cultures from 34 to 37 degrees Celsius. And a fungal culture was also done off that pericardial fluid, and that was negative. That was after 28 days at a slightly lower incubation temperature of 29 to 31 degrees Celsius. So then the patient was admitted with us at UW Health. On June 16th, pleural fluid was collected, and the bacterial culture was positive, but the fungal culture was negative. June 16th, GI pathogen panel had Yersinia. June 17th, blood cultures were drawn and were negative. June 19th, a lymph node biopsy was taken. Bacterial culture on that was positive. June 26th, pleural fluid, bacterial culture, again positive. Wherever it says positive, we're going to get to the organism because they're all positive for the same thing. And then June 27th, another pleural fluid, both bacterial and fungal cultures were negative. All right, so the pleural fluid that started growing with us. So this one was collected by the collection team we use Bactec at our institution, so into Bactec blood culture bottles. And we also incubate a chocolate plate with direct specimen when we do sterile fluids in Bactec bottles. So after 4 days of incubation, that direct chocolate plate started growing 2 colonies, very slow growing, and techs noted that there were possible feet starting on those colonies. 2 days and 20.7 hours after those bottles went into our Bactec, the aerobic bottle flagged as positive. So we pulled it, did a gram stain, did not see any organisms. We then followed up with an acridine orange stain, and that was also negative. Not too long after that, the Bactec signaled a second alert on that same bottle, and it was extremely rare, but some of the techs identified that it looked like a funky yeast. So we subcultured the bottles. 2 days later, those subculture plates were growing, and possible feet were again noted. The next day, after more incubation, and we now have several plates this is growing on, a tech noted this no longer looks like yeast or typical feet. They did a gram stain, it showed a possible fungus, and then they looked at the Bactec bottles that were held at the bench top after being pulled out of the instrument, and they noted what looked like possible fungus balls starting in there. So we subcultured all that to mycology media and referred it over to our mycology bench. And then the lymph node biopsy collected on June 19th. The bacterial culture, the thiol broth, was positive for growth on day 4. It was subcultured and determined to be the same thing as growing in the pleural fluid. And then the pathology on that lymph node biopsy said the core biopsy shows small, 2 to 5 microns, round to elongated yeast, no budding. One yeast form shows a division plane with the dividing septa. So then once it was at our mycology bench, it was very slow growing, so they were trying to do manual workup and exam microscopically, looking for structures, looking for colony properties, but it was just very slow growing. So we ended up having what we thought was some yeast growing. We tried to MALDI, no ID. So then we used our fungal MALDI extraction procedure, and we got a score of 1.52. I don't want to say what that was, because it will give away for your guessing in a moment. But I will say that this ended up being reliable to the genus, but not the species. So once we had more growth, the mycology bench did some lactophenol cotton blues to verify the genus. So I don't know, can I just ask how many people are trained mycologists in here or actually work mycology bench? I know in many labs it's kind of more of a specialty thing. So we've got a couple hands going up, maybe 5 or 7 or so. So I've got a couple more pictures of the lactophenol. Does anybody want me to stay on here for a minute longer to look at anything? Okay. So here's a few more pictures. And feel free if anything is coming to mind and you want to throw out anything. I see Alana getting very interested there. All right, so those were our lactophenols. And now we've got some pictures from our plates. So this is Sab high agar. This was after a few days of incubation, some yeast colonies just barely starting, but I admit you can't really see much that's helpful in this picture. So now here we've got a PDA. This is nice fungal growth. This is looking from the top, looking at the top of the colony. And then if we flip that plate over, we've got the bottom here. I think we might have some guesses. I see some nods and smiles. This was a PDA plate, potato dextrose agar, from our Bactec bottle. So after a lot of incubation, we've got a lot of growth on there, and that's looking at the underside of the colony again. And then this is a plate that was held at the bench top for several days, and then this was this organism growing in yeast form. I think one person has a guess. Yes, and so that is accurate, but did undergo a name change, and I heard that name change over here. Yes, exactly, yes. And I think Mark's going to take it back over here, but has anyone here experienced this or worked with it in their lab? Just textbook knowledge of it, okay.
So this slide, mostly for my knowledge, because sometimes you get your descriptions confused, especially in an organism that's changed names recently or changed identification. But this is a type of fungus that was thermally dimorphic and identified in 1956. But in terms of like how prevalent it is, it depends where you are in the world. But it was initially isolated from hepatic lesions in rats that are infected with these, and these were rats from Vietnam. The first case actually was recorded from a laboratory-acquired infection from presumably some of the technologists that were handling the animals. But the first naturally derived case was from a person with Hodgkin lymphoma. That might tie into something I'm going to say in a second. And historically, these were thought to be exclusively restricted to patients with HIV or AIDS or otherwise severe immunodeficiency. And it's pretty much endemic in places that most of us don't frequent unless you're on vacation. But basically, lots of Asian countries, and especially if you're native to that area and travel back and forth, this is something you may or may not be exposed to. And of course, Laos is one of the endemic countries. And so the idea here is, by showing this, we're not necessarily going to go through all of the developments with regard to discovery of this organism, but the idea is that this is actually relatively new to our understanding. And I don't know if the texts come out, but basically it was only in the mid-90s to 2000s that a lot of cases were popping out outside of like rare contexts with any regularity in patients that were receiving treatment for otherwise HIV and AIDS. And that was, at that point, had been about almost 50 years after this thing was discovered, or at least recorded in the literature. So there is not, it's not only newer in terms of our understanding, but there's also gaps in the knowledge and the experience of clinicians and microbiologists alike. In terms of mechanisms of infection, so this organism proliferates in macrophages and disseminates through the reticuloendothelial system, so it may be found in the spleen. It invades, when cases become fulminant, which wasn't the case here, we'll talk about that in a second, this invades multiple body organ systems. And the idea is that certain cytokines that are released by T lymphocytes and work on macrophages are normally important for host defenses against this organism. However, in cases of severe immunodeficiency, particularly HIV and AIDS, which specifically is a deficiency of certain types of T lymphocytes, this response may be blunted or not present at all. So it's a mold-in environment, yeast tissues, and this is the only dimorphic species in the genus, divides by septation and not budding, in contrast to other dimorphic fungi. And at 25 degrees, it grows as multinucleate septate branched hyphae with teardrop-shaped conidia overlying flax-shaped phyllides. At 37 degrees, it shows globe-shaped to sausage-shaped yeast cells. And it produces a distinctive red diffusible pigment, which I hadn't seen before, like physically, which is visible on agar media. And I just underline it because if you were able to isolate just the pigment, there's actually no pathologic organisms in it necessarily. So this has actually been used as like a dye for textiles in a past time. And it's, as we mentioned indirectly, it's determined to be genetically distinct from other penicillium species. This is once again mostly for my learning and knowledge. But this is kind of the different types of forms of similar dimorphic fungi and how they look. And Marneffii is at the bottom there. This is it up close. I don't think we have light microscopy in terms of panel B to resolve it at this power, but the red diffusible pigment is quite prominent here. So in terms of the case resolution, like I said, this wasn't a fulminant infection in this patient. This patient was actually treated with liposomal amphotericin B for 2 weeks and then 3 weeks of itraconazole. And the reason I mentioned that is because although this wasn't a fulminant infection, it is still quite a serious infection. And that is a very serious or a very, in some cases, toxic antifungal medication. And so that's why this patient had, for the time being that he was treated with amphotericin B, daily electrolytes to assess for any kind of associated renal toxicity, which may not always be present, but can be easily missed if you're not looking for it. In total, the patient was recommended at least 12 weeks of treatment, a lot of which he could have finished as an outpatient. And in the workup, in the time that he was being treated and being evaluated for this, the patient was known to have a family history of anti-TNF autoantibodies. So this goes back to what we were saying, where these T lymphocyte-derived cytokines that enable macrophages to clear the infection, this is one of those. And I don't think, even until now, this patient was found to have those, but he does have a family history that, if it was present in him, could give us an idea of why this patient was susceptible. Otherwise, it could have just been a community-acquired infection, being from someone that traveled to an endemic area. So in terms of take-home points, this is a dimorphic fungus endemic to the tropical Southeast Asia. It's not commonly encountered in North America unless you are evaluating those with a relevant travel history. It has the ability to proliferate inside macrophages, and when untreated, has an ability to cause disease in virtually every organ. As we mentioned, a T-cell mediated cytokine response is thought to be needed to mount an effective response to this, and a progression to systemic disease is common if the initial source is not controlled. And I think that brings us to the end.
All right, thank you. Does anybody have any questions about this case? It's very interesting. Thank you. Enjoyed it. Al, you want to go in that mic? Okay.
We'll see if we can answer
Great job, really interesting.
questions.
This is not a question, just a sort of funny story. My very first day on fellowship about the University of Washington, they identified one of these, first one they'd ever seen. And Susan Butler, who was the director at the time, she has a very potty mouth, and she came in just running in, holy bleep and bleep, you wouldn't believe what you just saw. And I had no idea what any of this was, but it's diffusible red pigment, and the patient was originally from Vietnam and was HIV positive. So it all fit also. But yeah, very cool case. Thanks.
Yeah.
Saba, do you want to go?
So I'm just curious to know, like, do you also perform slide culture or Dalmor plate cultures are performed for?
What was the second thing?
Do you perform slide culture for such?
Do not, no.
You don't. Not even Dalmor plate cultures, right?
What was it?
Dalmor plate cultures? No. Okay.
And I kind of missed the part of what was his immunosuppression or that made him susceptible to this?
It wasn't necessarily described. I think at the time we were presenting this, and even I checked recently, because of the family history of anti-TNF autoantibodies, there was an indication to do testing for that, except it's not like a normal in-house test we have. I believe it's something that has to be sent out. I don't remember if it's something that is like sent out to University of Washington in Seattle, or maybe even ARUP in Utah. But I don't think those were resulted yet. And I think on top of that, there was low suspicion. There was some discussion in the clinical notes about whether if he already had pneumonia at the time of traveling to Laos. That just may have been a perfect storm for something like this. But I don't think it was ever definitively described, in him at least. And you definitely don't need immunosuppression to get it, but it's overwhelmingly rare if there isn't a documented case of cause of immunosuppression. But great thought.
Kelly, I think most of us have not seen this in our lifetime. Very fascinating case. Can you describe a little bit more what it looked like in the thiobroth and the blood culture bottle? I mean, what was unique about it? Was it really a ball, or were you seeing diffuse things in there?
I didn't actually see the broths myself, but usually, like when we would describe a fungus ball in our lab, maybe it's what most of you would kind of bring to mind, but just, I don't know how I want to describe it, kind of maybe like you drop a little tiny piece of a cotton ball into some liquid and it just kind of floats around looking like a little fluffy feather almost. Sometimes you really got to hold it up to the light to even see it, kind of have the light catch it just the right way to shine off of it. Because otherwise it can just almost look like a little bit of turbidity in there, but if you really look, you can actually see all those nice little feathery looking structures in there. We didn't have any pictures of that. We didn't realize at the time how exciting this was going to get to take pictures at the time of everything along the way. Like our funky yeast stains and stuff, we would have had more of that to share if we realized what we were going to be working with at that time.
And I think you may have shown this, but could you just remind me, how long did it take to grow on your chocolate plates at 37?
The direct plate was 4 days, I think. And then, yes, the drug plate was 4 days, and then it took the blood culture bottle almost 3 days to go positive, and then 2 days subcultured from there.
Wow. So it's pretty fast growing. Mm-hmm. Interesting. Thanks so much.
Which is why I think people thought it was maybe like slow feet. They saw it was growing fast enough they weren't fully in the fungal realm for growth yet.
Okay. Or else I'll bring it over.
First of all, I was just wondering if you could show the pictures of the colonies again. And also, when you said it grew in the blood culture bottles, were they just regular blood culture bottles, or were they special fungal bottles?
Regular.
Okay.
These are aerobic and anaerobic adult bottles. Let's see. Anyone in particular that was of interest to you for the colony?
Oh, I've never seen one.
Picture, gotcha, yep.
That's cool. Huh. Anything else? All right, then thank you to both of you for sharing
Thank
this.
you.
wonderful case study. I think as long as everybody's sitting down pretty much, I'm going to go ahead. I'm going to keep us moving, and I'm going to begin with our lessons in defense against the dark arts. We want to give a little bit more time, if possible, to our last presentation of the day. So I have 3 lessons we're going to be going over today, so let's see. We're going to start out, we're going to go back to Harry Potter just for a minute to have a little fun. So in the Harry Potter books, which of these, or which of the following never taught the Defense Against the Dark Arts class? So you can go ahead and vote. See how many of you actually are Harry Potter fans. Okay, let's stop that and see what people are saying. So the majority say that it is, so we've got an A here and then a little bit of smattering of the other answers. And, okay, go ahead. Okay. I get always in trouble with this because I touch something I shouldn't, and then it doesn't want to work with the eye clickers again. All right, yay for the A's out there that knew that the right answer was Professor McGonagall. So all of the others, Severus Snape, Remus Lupin, Gilderoy Lockhart, and Mad-Eye Moody were instructors of the Defense Against the Dark Arts class. So why did I pick that title for the lessons here? Well, we'll find out. Okay, there was a recent basically a reclassification. It came out, the notice from the CDC Laboratory Outreach Communications. They sent out this notice that all of the Ochrobacter species were going to be reclassified into the Brucella genus. So last year when we were doing these meetings, we had a whole session on taxonomical changes and what that means for the lab. So now we had just Brucellas that everybody, when you had Brucella, you're thinking, oh my gosh, that's not a great bug. These are select agents. But now we've got a bunch of new Brucellas that are basically Ochrobacter species that are going to come in here and muck up the waters for all of us. So at the time that they released this information, they also said that all of the Brucella that were identified by rapid methods or by sequence-based systems, that they all needed to be handled within a Class 2 biosafety cabinet. That shouldn't be an issue. We should be working with our biosafety cabinets, but they actually wanted all those presumptive organisms to come into the state public health laboratories for final identification. And so the response with the public health laboratories was like, no way, I'm not taking all of those organisms. We don't want those all, so. Okay, whoops, I blew it. Okay. Too many clicks. You didn't see that. Okay, so how many of you know the correct answer? Let's actually give you a chance to vote on this. And let's see if you all get it right now and you saw it. Which Brucella species are considered to be the classical Brucella species that cause disease in humans and must be reported as select agents? Okay, let's see what our answer is. Okay, well, most of you are looking at that slide. So the answer is actually Brucella suis, Brucella abortus, and Brucella melitensis are the 3 agents, or the 3 Brucella species that we typically associate with human infection. So let's go and talk just a little bit of a refresher about classical Brucella species. So the agents that are highlighted in red here are those agents that can cause human brucellosis, typically. There are a couple of others, rarely that will cause brucellosis, and that is the vaccine that is for cows, and it is the RB51. It's the Brucella abortus RB51. And then occasionally, actually, you can get brucellosis from Brucella canis in dogs. And there was just a report on ProMed, talking about ProMed, yesterday, I think it was, wherever Al is, that made an announcement that they had 3 cases of brucellosis with humans in the UK that were Brucella canis. And it was, they'd never had this before. And they were having this outbreak of brucellosis going on in dogs. So typically, if you get Brucella, people who get Brucella are people who have contact with animals and close contact with animals. Some of the activities that might predispose them to getting Brucella would be helping with birthing processes or maybe dressing a carcass, just that close contact. But we all know that Brucella is a select agent because it can be weaponized, and you can get it by inhaling it, you can get it in a wound, you can get it in your mucous membranes. So there are other ways you can get it, but these are typically, all of these Brucellas are typically hosted, or their typical host is a mammal or a reptile, and then humans can occasionally get some of these. One thing about Brucella is that there are over 500,000 cases of brucellosis reported each year. The most commonly reported Brucella is Brucella melitensis, although Brucella abortus is really more widespread with all the cattle in the world. But they don't think that they think this is an underreported number, this 500,000 cases, because they don't think that the disease is often recognized. The symptoms are very vague. They can be a lot of different things that would have the same types of symptoms: headache, fever, malaise, arthralgias, myalgias. And so it can be difficult to identify. Brucella can often be focal and attack any of the organs in the body. Often it will attack the joints, so you have, and bones, and then also the reproductive system, which is why often in animals it's associated with abortion, what am I saying? Well, I guess a natural abortion. So anyway, so that is typically where those are seen. Now let's go on and see which are the organisms that are new Brucella. So all of those organisms on the left had the Ochrobacter names, and now they are all reclassified as Brucellas. The most commonly found Brucella Ochrobacter species are the Ochrobacter or the Brucella anthropi and the Ochrobacter Brucella intermedia. So those are the most common. These are typically soil and water organisms. With an infection, they're often more of a colonization, and frequently they are found in patients who are immunocompromised, so they're an opportunistic type of a pathogen, often associated with people who have maybe cancer, or they've had some kind of a surgery, kidney issues, Crohn's disease, something that's putting the patient more in an immunocompromised state. So what are the implications of adopting this Brucella name? This is an issue because some of the manufacturers are already adopting the new Brucella name for the rapid ID systems. And so you may be seeing these new Brucella names coming off on some of your rapid systems. And you have to decide, what are you going to do? How are you going to report this? How does this make sense? If you report a Brucella anthropi suddenly, and you don't have a comment, and you haven't done any education to your clinicians or anybody else in your healthcare system about this name change, this is going to be a problem, because the clinician is potentially going to see Brucella. They're going to start treating for brucellosis, and so they're going to give antibiotics for that. So they're going to give doxycycline and I can't remember, rifampin, I think is what it typically is. And whereas if it's an Ochrobacter infection, it's going to be one of the newer fluoroquinolones, I can't say the word, or it could be like a aminoglycoside, something else, some different kind of an antibiotic. There isn't a lot of resistance with the true brucellosis. You don't see resistance to antibiotics, but you might see it with the Brucella ochrobactrum, so you have to know what you're doing with. You don't want to be performing susceptibility testing if your system is telling you one thing and then maybe you really don't have that. So there's also a problem for infection prevention. So you've been working with an agent. Now do you have maybe exposures in your lab? If this is a true Brucella, do you need to consider post-exposure treatment for people who may have been exposed? Is this a Brucella or not? So those are things that you have to think about. If you are going to be sending it to either a reference lab, well, it shouldn't go to a reference laboratory if it's Brucella. It should come to us as your LRN reference laboratory if you're not sure what Brucella it is. If you're sending it to us, though, how do you package it? It should be a category A if it's a true Brucella, where if it's Brucella ochrobactrum, it doesn't need to be. So there's this kind of conundrum that's out there, what's going on. So the Council of State and Territorial Epidemiologists needs to figure out what the case definition is of brucellosis now, and that needs to get adopted and changed. So this is just a chart that shows basically some of the things that I've already talked about, comparing the Brucella ochrobactrum species to the classical Brucella. So this is there. This is a good reference that you can look at if you want to pull up these slides after you get back in your laboratory. Okay, so there are problems definitely with the automated identification systems. So this is a pun on the Weasley brothers. Is it George or Fred, or is it Fred or George? We all know that with twins, sometimes it can be really difficult to tell twins apart until you know them better and you know these little bitty characteristics that one might have versus the other that, oh yeah, that's George, no, that's Fred, okay. So with our systems, they can either misidentify, so they could call a true classical Brucella species as one of the Brucella ochrobactrum species, or vice versa, they can do it the other way around. Or they may not give you any identification at all, because the systems just aren't that good with differentiating those organisms. So it's a problem. You're going to have to do a little bit more testing within your laboratory to figure out what it really is. So we asked, I think there were a lot of people that were trying to work on putting some guidance together for clinical laboratories to see how you can look at these and kind of do some rule-out testing. So we know commonly that the Brucella ochrobactrum species, they are a gram-negative rod, where the true Brucella species, it's a gram-negative rod, but it's tiny. It can be a coccobacilli, and sometimes it even likes to hold on to decolorizer, and it can stain gram-positive. They're hard to tell when you see them in a blood culture bottle. They can be so tiny, they're just not always recognizable. Where the Brucella ochrobactrum is a little bit larger gram-negative rod, and so it's more the size of like an E. coli type Enterobacterialis type organism. We know that true Brucella doesn't grow on McConkey's agar. So if you have something that is growing on McConkey's agar, it is probably not one of your classical Brucellas. They're not supposed to grow on McConkey's, although there was a case study I heard recently where somebody out in New York got fooled, a lab, that they had a bunch of exposures because their Brucella actually grew on McConkey's. So just know that, you know, the organisms don't read the books that they're supposed to, and so they don't always do what we expect. If you have a mucoid colony, classical Brucella typically are not mucoid, so it's probably then one of the Brucella ochrobactrum species. And it may have a positive motility. And if you're going to do a motility, they recommend doing a tube-based motility and not to try and do a hanging drop motility or anything. And if it has a negative urease, true Brucellas are going to be urease positive. So if it's negative, most of the ochrobactrum Brucellas will have a positive urease, but some of them are negative. So if you get that, then you know it's not one of your classical brucellas. So again, this is a chart that can be helpful, and you can just see some of the differentiation things here. Again, the McConkey's is a really strong one. That colony morphology may or may not be helpful. The urease may or may not be helpful. And it's just a little bit difficult to tell some of these, but these are the best things that we have actually in our book right now to help us decide which of these agents are which. So if you take out that handout in your folders, there are these pictures. So basically what I'm pulling these slides from is this document plus another webinar where they gave us some information to try and help you in the clinical laboratories that I've given links to in this presentation. But you can look at the pictures and you can see that those classical brucellas, and so small I can barely read it myself. I need my reading glasses. They just don't grow on the McConkey's at all. You know, at 72 hours, they still aren't growing on McConkey's. And there's slower growth, probably even on blood and chocolate for a classical Brucella than the others. The gram stains, what can you say? I think this coloring, and it's hard to say because I don't know how you can compare directly to one to the other, but for the Brucella malatensis, they just look tiny. They're just a smaller gram-negative coccobacillus, and they may stain a little fainter, and just something to look at, just so that you have some pictures if you ever see one of these in your laboratory that you can refer to. So another thing that might help you in differentiation of these organisms is to know the clinical history. And so whenever you call our pager, if you get a hold of me, one of the first questions I'm going to ask you, if you tell me you have a suspect select agent, is I'm going to say, did you talk to the clinician? And we want you to do that, because if you talk to the clinician and they have no reason, they haven't worked with animals, they don't have pets, they don't eat unpasteurized dairy, they haven't traveled anywhere, those things are going to say, well, it's probably not a classical Brucella, but it can help you to have that conversation. I mean, are there symptoms consistent with a classical case of brucellosis or not? Where again, the Brucella ochrebactrum are just these common soil water type of organisms that cause these immunocompromised type, or cause infection in immunocompromised patients. When you're working in the laboratory, think about a couple of different things. So if you have this slow-growing isolate and you're not getting any growth in McConkey's, your radar should go up and you should be thinking, okay, this is probably a select agent. What do I need to do? So you're going to immediately take any work and go into your BSL-2 and maybe take some additional BSL-3 precautions and start performing your classical rule-out testing for select agents. And then again, contact your clinician, see what's going on, notify us, and we will help you. You can submit it to us if you're unable to rule out a Brucella, and then again, package and ship as a category A. So the procedure is the same no matter what, but you've got 3 different situations where it's slow-growing, or a slow-growing isolate and no growth on McConkey. If you get a rapid ID of Brucella or ochrebactrum of any species, try and do that rule-out testing first if you need to. And then if you have a MALDI ID of Brucella or ochrebactrum of any species, those are the agents we're really interested in here. But try and do as much ruling out as you can before you would send something to us. But do it safely. If you can't do it safely, don't handle it just to try and do a bunch of testing. Make sure that you're in the BSL-2 and you're doing things safely. So for the laboratory, you have to decide how you're going to report these organisms. So internally, document in your patient workup, however you're doing that on your whatever LIS system you're using, make sure that you put in there, if you've done rule-out testing, write in there what you've done. This isn't information that needs to go to the doctor, but you need to have it. If there's any question, you need to go back to anything. So document it in there. But then you need to decide how you're going to report these organisms. Are you just going to keep reporting them as Ochrebactrum? Nobody says you have to change the name, or are you going to go to Brucella with Ochrebactrum in parentheses afterwards? How are you going to do that? And that document, again, that I gave you has some suggestions and some discussion about different ways to possibly report these agents. But again, you're going to have to probably provide education of some sort. And we were just having a discussion at lunch about how it can be difficult to provide education to clinicians and get them on the same page so that they know about this change now and that they're just not hyperventilating every time they see Brucella on something and making, a jump decision on what they're doing with that patient. For the clinician, you need them to understand that they don't need to treat for Brucella or brucellosis if it's the Ochrebactrum infection. So they need to be aware which set of antibiotics are they using and use the correct ones for the patient. And for any state and local epidemiologists in here, again, don't report brucellosis if you're seeing an ID coming across a Brucella something. Make sure you know which are the species that are the ones that cause brucellosis versus which are the Brucella Ochrebactrums. So is this all confusing to you? Yes? Hopefully it's a little less confusing. You just need to be aware that this is out there. And so these taxonomic changes do impact us in the laboratory. And this is the first one maybe that's happened where we've had it be with something like a select agent like this, but it's just part of the laboratory. We'll get used to it. It's another new one that we've got to learn a new name. Okay, any questions before I move on to our second lesson? Okay. So one of the things when I get to go out and visit laboratories and talk to them and ask about how they're doing with things, a lot of times I hear that people are confused when they have to do our bioterrorism exercises. And they don't really know how to look at them or what to do with specimens. They don't know which charts they're supposed to be using. So rather than having an owl that I send to you to tell you what to do, when we have these exercises and they come out twice a year in the spring and the fall, somebody in your laboratory, typically a director or supervisor, somebody in the laboratory is receiving a letter from me that says, you're getting these 2 samples, be prepared to get them. And I give them the links to the resources that you should be using. And I tell them to make sure that the person who's performing the testing gets that letter from me so that they see this too. I don't know if that's happening or not. If it's not, and you're the person that's going to be doing the testing on these organisms, ask around, find out who got the letter. If nobody got it, ping me, contact me, and I can send you that letter myself. So follow the directions that are on the letter, and then think about this as an exercise. This isn't a proficiency testing anymore. Even the CAP LPX was changed. We don't want it to be something that somebody comes in when you're getting inspected and looks at, oh, they failed. This is meant to help you so that when you get these true agents that can be select agents that are just probably normal, that are out there that we do run into every day, the Franciscellas, the Brucellas, the Yersinia that we know are out there. We want to help you so that the first time people in your laboratory are seeing them isn't when they get that isolate on the bench, that they've had a little bit of time to practice. So read the instructions that come with the package. Perform all of the work in a biosafety cabinet until you can rule it out. We aren't going to send you the real bug. We're not going to send you a real Brucella or a real Yersinia. But we want you to pretend that it is so that people get used to just moving those into a biosafety cabinet right away. I don't have a magic wand to send with the exercise that you can just swish around and gives you the right answer. You're going to have to do a little work. So there's a provided, you're always going to get a scenario that is very leading to lead you to the agent you should probably be suspecting. You're going to do that initial gram stain. And this is the start of your exercise to try and identify these things. Set up your culture on blood, chocolate, and McConkey's, and then always subculture any growth twice, not just once, but twice before you actually perform the rule-out testing on it. Lyophilized agents don't perform well at first, and so if you want the best characteristic types of reactions, you need to subculture them at least twice. Don't use growth rate alone to rule out a BT agent. We all know these aren't the real bugs. I already told you they're not. They're just simulating them, but most of them are going to grow faster than a true select agent. So if you just put on your report form, it grew at 24 hours, it's not a select agent, you didn't get anything out of the exercise because you didn't practice anything, and it's not really what we want you to do with it. You will get failed. Do note which auger the organisms are going to grow on, and note if there's any hemolysis, and then go ahead and gram stain the isolate. So obviously if it's a gram-positive bacillus, is it large and boxcar shaped like bacillus or small and thin? We're trying to work on your ability to rule out bacillus anthracis if you're seeing something that's a fairly good-sized gram-positive bacillus, okay? If it's a gram-negative bacilli or a gram-negative coccobacilli, then you also have another page in your handouts. Then we want you to go to that page 13 that is linked here, and you will see a rule-out chart. Okay, so here's another gimme question. Which select agent that is considered to be a gram-negative coccobacillus can sometimes stain gram-positive? Oops. Okay, everybody got it. Brucella species, yay. Okay, so now we'll look at this chart. So when you look at this chart, it's fairly easy to start out with. Let me get this pointer, if I can get this to work right. Oh, I can't do this on here. Having these iClicker questions doesn't help when I'm trying to show you something else on here. Okay, so number one is looking at growth on McConkey's. So if you have growth on McConkey's, you're going off to the left-hand side looking at this, and you have two agents that you're ultimately going to consider. You have a Burkholderia pseudomallei or Yersinia pestis. If it grows poorly or not at all on McConkey's, then you're going over to the other side of that table or flow chart, and you're going to have Brucella species, Burkholderia mallei, and the Francisella tularensis. So you can see how that's working, right? Then if you go to the second step, the next thing you're going to do is a catalase. So catalase positive is pretty explanatory. People get a lot of bubbles. They're happy to call it a catalase positive. What happens, though, when you're only seeing one or two bubbles? Is that positive? Is that just negative? We're going to tell you that you really should be doing a catalase rather than putting some organism on a slide and dropping your hydrogen peroxide onto the slide on top of it and watching the bubbles, which causes a lot of aerosols. We're going to ask you to try and do that in a tube. So if you wanted to put your bug in a little test tube and then put your hydrogen peroxide and just run it gently down the side of the tube, you shouldn't be getting a lot of aerosol, and any bubbles would be true production of bubbles when you're doing that. It's a little bit safer for you, and maybe it's a little bit easier to read. But just document what happens. If you see one or two bubbles, then you know that's all you had, and that, to me, would be a weak positive. And then if you're on the left side of this flow chart, they ask you as a 2A to do an indol, which should be positive to be one of those two agents. And then basically, after you're doing the catalase, you're going on to oxidase for the number 3. So labs should have in their laboratory catalase and oxidase reagents. You should be able to do those tests at a very minimum. And then you work yourself down through the charts until you get through the other testing. So what do you do if your laboratory doesn't have all the biochemicals that you need to rule it out? So as I just said, at a minimum, you have to do the gram stage, catalase, and oxidase, and that's what we expect to see at a minimum on any results that come back to us. And we know that you might not have some of those other reagents and tests to do rule-out testing. One thing we want you to do, though, is if the test isn't indicated on the flow chart, once you get down to one of these columns, then you're going to go to the specific page for whatever agent you're still trying to rule out. If there's a test that's not indicated, we don't want you to perform it. This is for your safety. If this is a real organism in your laboratory, the less manipulating you do of it, the less chance you have of having exposures and having any laboratory-associated infections as a result. So we ask you not to do that. So perform the tests that are indicated, document your results. If the test isn't indicated, then go ahead and use the test not indicated result. Don't use the exception code that the procedure isn't performed in-house, even if that's true. We want to know, do you know that that test isn't indicated? So we're looking for a test not indicated result on the ones you don't need to do. If a test is indicated and you don't have that ability to test it in-house, that's when you use the exception code on the exercise, the procedure, or that source isn't performed in-house. And then you can also add a comment that normally, you would perform this test, this is what the test would tell you, and then we know that you're thinking along the way to actually rule out this organism safely. And use your comments. This really helps us. I think the most difficult thing to do, I've looked at these in the past, and I've looked at them with our proficiency testing division that conducts these exercises. It's really difficult to grade these. So the more comments that you can provide, the better we can understand what you're thinking and know that you're doing things that would help keep you safe in your laboratory. So this is just an example of the form. And so if you had growth on blood and you first got it at 48 hours here, okay, then give us a comment. Okay, I had slight growth at 48 hours. If you had chocolate and it grew at 24 hours, and that was when you first saw slight growth, say it was slight growth at 24 hours. Tell us exactly what you're seeing and what you're thinking. Growth on McConkey's, you're saying no growth at 48 ever. It just didn't grow. So put the comment in. Hemolysis they ask you for, so record what was your hemolysis. This was not beta hemolytic. The gram stain, again, help us to just see what you're seeing by what you're telling us on the report. So gram-negative small coccobacilli. So that's what you write over here, tiny GNCB. And then they ask a little bit about, well, which agents that you're ruling out so far. Okay, so I had a gram-negative coccobacillus. I can rule out bacillus anthracis, and you can write that down here. I didn't have any growth on McConkey's, so that helps me rule out that Yersinia and the Burkholderia pseudomallii. I can rule those two out, so then you know that you're looking at those other three. So by putting these notes in, you're really helping us understand that you know what you're doing and following these flow charts and working with these organisms safely. When you get to the analyte fields, you have to put something in all of these fields. So here again is the catalase. I had a weak tube catalase that was positive, and I had 2 bubbles. So we know, why you're calling it weak. You had 2 bubbles. Had a negative oxidase. With the indol, it's a test that wasn't indicated, and so on. And so you're going in, and then down with the satellite. Okay, that was a test that was indicated, but you didn't have it, so that's where you used an exception code. Are you following me? Does this make sense, everybody? Okay. And then at the end, when you have to go on to the final page for the rule out, then you can go ahead and go through each of the agents and tell how you actually ruled out each of the agents. You check the box, but then you're also giving us the comments. And that is the easiest way for us to grade you correctly. And then always on the bottom, you should say that you would be notifying the LRN lab, and if it's a true organism, we're going to be notifying local public health, and we're also going to be notifying state public health. And you would never knowingly send one of these to your reference labs that are not our LRN lab. Okay, clear, forms okay, following okay, didn't lose anyone too badly. All right, so again, anybody who remembers, I can remember this scene so vividly from watching these Harry Potter movies with friends recently. Even when in class, they were first learning how to levitate and use their wands and things, it wasn't a simple thing. They were all trying to do this spell to levitate this feather, and they had to say the Wingardium Leviosa. It couldn't be Wingardium Leviosa, as they said in the movie. I laughed at it so hard. It was like, there are techniques that we have to learn, and that's where practice comes in. And so practice, use these things to practice. When you get your results back, review them with the employees in your laboratory, anybody who's working with these specimens, so that everybody can learn. And if there are failed items, why did you fail? Look at that. If you don't understand why you failed it, that's when you call me. And sometimes when we're talking things through, I have actually disagreed with how something was graded, and I might change the grade on something when I go back and say, I don't think this is wrong, what they were thinking. So that can happen too. So I am your friend for these exercises. But use and then set up the remaining swabs. Use them to teach new staff. Use them to teach students, and just kind of practice some of these tests. With real patient culture workup, and that's what I'm most interested in, we get calls, not just me, but at the state lab, we get calls a couple times a year where somebody ends up having, a true Brucella, a true Francisella, and most often there are exposures in the laboratory, and we help you identify that and work with you through that. But if you know some of the stopping points ahead of time, then you really explain this to people and go over this, remind them about this. There are things you want to move into a biosafety cabinet. So when you're working with, think about whenever you're working with blood, wound specimens, including animal bites. Animal bites are the biggest problem. This is the wound that people often get caught on, or a lower respiratory culture. Those are certainly cultures that you could identify one of these things. And so you want to think about it, and potentially, if you can, work with it in a biosafety cabinet. And again, knowing what your gram stain should look like. Is it the large gram-positive bacillus, boxcar shaped? Is it the small pleomorphic gram-negative bacillus? Or that tiny gram-negative coccobacillus. When it first grows, is it growing in your blood culture bottle at greater than 24 hours? You can set a time limit. Maybe it's 36 hours, maybe it's 48 hours, but often your normal pathogens grow within 24 hours. Isolate growth, when it's that teeny tiny haze at negative 24 hours, or sometimes even at 48 hours, these things aren't growing well yet. Is it growing better on chocolate than blood? Is there no growth on McConkeys? These are all those indicators that you need to think about. And that being said, I know that some of the healthcare systems, you have developed your own flowcharts that you work with internally, and that is fine. I'm not going to say don't use those, because that is a policy that works for your laboratory, but you still need to know these stopping points. And if you've decided something other than the standard flowcharts that we provide for you, and it works for you, and that's what your system does, then you're going to do that. So, but think about what you're doing anyway. Just be careful. And never use an automated ID system or a MALDI on any of those types of agents until you've ruled them out. So again, before you would put it on MALDI, perform any rule-out testing that you need, according, for me to say the APHL bench card flowchart. Consult again with that clinician to see what that patient history is, what kind of symptoms they have. If there's something that you're not sure about, always give us a call. We're happy to help you think through or potentially identify one of these agents. And then make sure that you have staff that are knowledgeable in sending suspect category A specimens to us at the state. And if there is something that we would identify as one of the select agents, make sure that you know how you're going to gather all of those cultures that you may have on that patient that could have that organism growing on it. You're going to have to gather them all together and make sure that you destroy them as part of that select agent reporting if we identify that. So they're going to want to know how you destroyed that. Okay, so that's enough about those organisms and working with them. Everybody okay? So this is another problem that's come up. So I'm going to go to this final lesson quickly here before we go on to something else. But this question is, what would you do if you're working on a second or third shift and you believe that you were exposed to a BT agent? So go ahead and answer whichever you think you would do. Okay. So a lot of you would check your biosafety plan and then follow the guidance. Okay, and then there's one answer of a B and a C. So let's see what the right answer is. So I was hoping that that E was the one you would check and check in your biosafety plan. Maybe you don't have a biosafety plan though, and you know that, so then maybe going to the ER is, the thing that you would do. But this is what I want you to think about. If you don't have some biosafety plan that tells you what to do, let's think about doing that. When you're determining whether or not you've had lab exposures, it's going to be a whole team of people who needs to be involved. And waiting until the exposure happens isn't the time to assemble that team. So think in advance who needs to be there. So you've got your clinical laboratory, you've got us at the state laboratory, we've got public health, state and local public health, we've got employee health, you've got infection prevention, potentially occupational health. These are all potential partners on your team that need to get involved in determining what's going to happen. So go back now if this isn't already in your plan, assemble that team, get all those people written down somewhere, and then make sure everybody knows what job they're responsible for. So another question is, do you have a biosafety plan that includes information on what to do if there is laboratory exposure? And let's see how you vote on that one. Okay, let's look at the results. So there's a lot of A's, a couple B's, and a D and an E, no C's, okay. So A is what we had hoped, is that you have these things in a biosafety plan, but it isn't uncommon that you might have information, but it's not all compiled in your biosafety plan, so then is it somewhere else that you have in your laboratory? Just so you know where that is. If you don't have any of this, those are the people I'm really wanting to talk to right now, is please go back and put this together and think about what I'm saying, and if you need any help with it, call me. So let's shed some light, lumos, on what should be in your laboratory biosafety plan. Okay, in your biosafety plan, you should have information about the following types of things. Vaccinations. What vaccinations are you offering to the individuals in your laboratory? What's the scope of the work that you're performing, and what vaccinations do they need? So there should be something about your vaccinations. That's part of it. Biosafety training is another component. So what do you do for biosafety training? You can't assume that people coming into your laboratories have all had biosafety training, especially in the days now where we're hiring non-traditional types of people with different degrees than maybe are traditional in our laboratories because there aren't enough medical laboratory scientists. So we hire people that may not have had a lot of biosafety training. So what is in your plan and how do you train? Then also, how are you assessing competency, that they have these biosafety skills? Once you've trained them, how do you assess that competency? A big part of any biosafety plan should be risk assessment and then mitigation steps to mitigate risks that you identify. That is a continual process. Every time something changes in your lab, new equipment, new testing, changes in personnel or placement of things in your laboratory, and potentially new personnel can also have an impact if they come in and they have some type of compromised situation that they're dealing with. Those things can change the risk assessment for them potentially. And then the exposure assessment tool, we've been using one. When we get a call, I call the people at the state or the State Communicable Disease Bureau, and we work together to get you an exposure assessment checklist that we've been going through with you. APHL is finally supposed to be getting the one out that we have worked on for years now, that we based that checklist on. They're supposed to come out with that tool by the end of September, early October, and it should be ready for the ABSA meeting in October. Incident reports, how do you file, what forms do you need to file if there's been an incident in your laboratory? Where are those kept? Who completes them? How long do you have? Names, again, of the contact information, we already said that. And then at the end of all of this, once you go back and do the exposure assessment and figure out what any prophylaxis or monitoring that needs to be done, how many people were exposed, go back and do that root cause analysis and try and figure out what happened, why did we have this exposure, what do we need to change, can we do something differently so that this doesn't happen again. Again, just talking about risk assessment, things to consider that maybe you don't think about. This is an everyday thing. What are you working with? How hazardous is the specimen? Do you know? Probably not. Where are you working? Are others working nearby you? What testing steps, what manipulations are you doing with this organism or culture? What is your personal immune status? What's your mental status? So are you very with it today? Is it a bad day for you? Did something happen? And then with risk assessment, this is something that everybody in the laboratory should know how to do. It shouldn't be just a supervisor or a director or maybe a technical lead that does this. This is something every person working in the laboratory should be able to assess risk and look at things and maybe bring things up that maybe other people didn't notice and say, hey, this is a risk. Is there something we can do to lessen this risk for this particular thing that you're doing? So it's constantly, renewing and reviewing these risk assessments. So this is the exposure assessment tool that's supposed to be coming out. It basically asks what work was done by whom, where, and what PPE was worn, who else was present, and how close were they. And then there's a section about the monitoring or the prophylaxis. Who needs treatment? What is that going to be, and who's monitoring it? And this is just kind of a review of everything that we've just been through. Okay, and then finally, there isn't a set root cause analysis tool to use. This is just one example of one. The root cause analysis, again, is getting at the root of what happened, why did something happen. It's underneath, you don't always see it, so you can ask 5 whys and try and keep digging deeper and deeper and deeper into trying to find out why something happened. And so there's just an example here that there was an exposure of somebody working with something, and they worked with it outside a biosafety cabinet. Somebody was in the biosafety cabinet. They didn't want to wait. They had an issue. They wanted to get out of the lab on time, so they worked on an open bench. They didn't follow procedure. So basically, they didn't have any regard for what the standard operating procedure was that said they needed to work in a biosafety cabinet. Again, after something happens, you're going to repeat risk assessments again, add additional mitigation steps. And again, all of this is done because we want to keep people safe. I don't want to hear, that you guys have been exposed to something. I don't want to hear that you have to take antibiotics. It always makes me sad when that happens. But it does, and if it does, then that's okay. Then we deal with it, and we get you the help that you need. So basically, this is a preaching of don't wait, teach now, prepare now. Make sure that you're ready to deal with these dark things that you might encounter in the lab, on the bench. So stay safe and have your wands always ready. Okay, any questions?
Yes, regarding Ochrobacterium, so there was an interesting paper, some of you may have seen it, it was in last month's JCM, and it was by a group, Moreno et al. I mean, et al. There was something like 75 authors and 29 institutions. To add to what Erin says, you don't need to accept that there's no taxonomy police. It's kind of complicated the way nomenclature works. I won't go into the details, but if you're interested in having an alternate analysis of why that change was done prematurely, I would direct you to that JCM paper. It was pretty interesting. Basically, their point is that those taxonomists kind of jumped the gun. And while the name change to Brucella was validly published, it maybe should be revisited. So it's a good article, yeah. And for us, we won't be doing it because, our group, including ID docs and infectious forensics, we just, no matter, we're so big trying to, educate. No, that's not really Brucella. It might be Brucella, but your patient doesn't have brucellosis. We're not going to do it. But it's a good paper. Yeah, I think it's well thought out.
Thanks for that, Tom. I appreciate that because I think that's a real valid option for people is if they don't want to adopt the change, just make sure that then the techs that are taking those reports off your automated instruments know not to call it that new name it's giving it.
Well, at some point they will be updated very potentially, yeah.
Yeah. Ray.
I'd like to ask the folks at the state lab, when we send you a small coccobacillary gram-negative rod that we can't rule out Brucella, what are the first things that you do with it?
Yeah, you can probably help me with this too, Erin. So first thing that we're going to do is the same rule outs. Surprisingly, there's a fair number of times, sometimes the wrong isolate is sent to us, sometimes it's mischaracterized in the laboratory. So we'll start with the same rule outs, and then we can evaluate it a little bit further. The key part is that we're going to be working in a biosafety level 3 laboratory with extensive PPE and protocols put in place to help prevent potential exposures to our staff, to other people who might be coming through the laboratory. And for our more definitive identifications, our lab-developed PCRs that are given to us by the CDC that have specific targets to identify the different select agents. So we'll still look for growth on blood, chocolate, and McConkey. We're going to do gram stains. We're going to do urease, all the same kinds of things that you guys are doing, but then we take it a step further with the PCR, and we do have a couple other tests depending on the pathogen that would go a little bit further, phage testing, things like that.
And we do have the advantage of seeing all of those isolates you send to us, so we have a fairly good sense when we see the isolates just from that, seeing it more often, the way you get that kind of expertise. A lot of our staff, they can, they'll do all the testing, but they'll kind of know up front often by looking at things that, no, this isn't going to be one, but we still do it. We always check, so.
Yeah, and the likely organisms are also sent to CDC for additional characterization and reporting as well.
So. Any other questions? All right, thanks. Okay, then we are going to move on to, there's a couple of things I want to do right now. We're going to move on to our last presentation of the day. This presentation is going to be delivered by two of our lab TAG members today, Dr. Raymond Podzorski and Dr. Thomas Novicki. And this is a labor of love. We've really struggled with this and talking about how to do this. We told you in the past that there's this new regulation coming out in the CAP inspection questions and things about having to adopt these breakpoint changes within 3 years that they've been adopted. And so we tried to figure out how we were going to give this information into people that needed help doing this. Some of you have large systems and you feel pretty capable about doing this, but some of you in smaller laboratories really were struggling with, what do I need to do, where do I start? And so just understand there were a group of people that actually worked on this presentation. We have two of them today to present, but they really wanted to try and help you with this. So hopefully you'll find this presentation useful. And if you do have questions, please do ask. And with that, I think I am fine, and I can turn it over to Ray.
All right, so for the last talk of the day, probably something that in our laboratory is always something that we're seen with consternation when we see that there's new interpretive criteria for certain bug-drug combinations. And you know, there's kind of a hodgepodge of information out there. There's some CLSI documents. There's some information that's been put in for breakpoints, like Tom mentioned back in 2010 when those kind of were put in. They put together a few things. But there was really, you know, nothing all kind of bundled together to help us with those breakpoints that were being changed right now. You know, and so, you know, help, you know, what to do, how many isolates do we need, what kind of calculations do we need to make. So now I'm going to try this and see if this works.
See, is it on still?
It's off, turn it on. There we go. So now there actually is what's called a breakpoint implementation toolkit to actually help us work through this entire process. And Tom and I are going to just kind of present this kit. The part I'm going to present will be really kind of the introduction and a couple of things you do to get ready to determine what work you need to do in terms of new breakpoint evaluations. And then that's the part. And then the other part is actually doing the breakpoint update and the tools you need, and Tom is going to work on that part. And a couple of recent CAP requirements has really kind of, you know, pushed this issue to the forefront. And these things that you will be doing with this breakpoint implementation toolkit from CLSI will help you to meet these two CAP requirements, and we'll talk more about these later. So I'm going to do the introduction, which was put together by Jorn Bansberg, a member of LabTag, and I'm also going to be doing, again, that work, talk about those sections in the toolkit used to get ready to see what you need to do. So this 2013 toolkit was put together by a number of different laboratory organizations that you're all very familiar with. CAP, CLSI, Association for Public Health Laboratories, the CDC, and the American Society for Microbiology. So we have Voldemort here telling us, yeah, this is the kit you want to use as you work through this updates for these breakpoints. So why do we need to do updates? Because for our instruments that most of us use to do the bulk of our susceptibility testing is they don't keep up with breakpoint changes that come down from the FDA or CLSI. They can be years behind in terms of what they're FDA cleared for and what actually is in the instrument. So you know, a lot of these breakpoints were initially put together many, many years ago before many of these antibiotics weren't even on the market that have been pressuring the organisms. So if you want to be up to date and be current, you're going to have to do these breakpoint evaluations yourself in order to be able to report these new guidelines. So the Breakpoint Implementation Toolkit is summarized right here. And I'm going to go through the introduction, as I'd mentioned. And I'm going to go through Part A, which is getting you ready to see what you need the breakpoints in use. And then I'm going to talk about how you can get a real quick place to look to see what the current CLSI breakpoints are and what the FDA breakpoints are, to compare them with what breakpoints that you're using. And then Tom is going to work on Part C, which is kind of at the end, the breakpoint implementation summary, as well as D and E, which are where to get isolates to do these breakpoint verifications, and F and G on how to use the forms, use the spreadsheets. And these are a really nice arrangement of forms that are set up for a number of the current breakpoints that we need to update now. They do all the calculations for you. And the one thing I've found is that, you know, you don't have to use every piece, every part. You know, I'm kind of one of those that doesn't look at the directions and just starts playing around with the spreadsheet to see what it does. So you can do all or some, or if you've got parts you've already put together over the years, you can take that and put it together with what is in the implementation toolkit. And one really nice thing is that for everything you see here, there are short videos at the CLSI website. And some of them are only 3 or 4 minutes, some are 15 to 18 minutes. But those are really helpful as well to really give you the high points about each one of these sessions. So let's go through the introduction a little bit more in the toolkit and see what's in there. One thing that's in there is this sheet here, and it's just a sheet to show you. On the left, it's a pathway for updating breakpoints. That's a breakpoint assessment. For each organism, group, bug, drug, components that you might have, this goes through to determine, do you need to update your breakpoints for that organism group and that antibiotic? If you do, the breakpoint validation verification, on the right, is the process that you would then follow to update that breakpoint if necessary. And then in the introduction, there's a nice section on just a summary on how to use the toolkit. Briefly talks about the various parts, A, B, C, D, E, and F. Talks about a couple of terms that are always kind of a big part of when you have a new test, not just breakpoint. You know, what's a verification? What's a validation? That's right in here in the introduction. And then they have a very nice table that's specific for breakpoint updates on situations where it would be a verification, which doesn't require as many organisms, 10 to 15, or if it's a validation, where you're looking at 30 organisms that are going to need to be used to update that breakpoint. Have a very nice table with lots of hyperlinks on resources. It has, one that'll go to the CLSI M100, the current one, which have the current CLSI breakpoints, a link to the FDA site for the FDA breakpoints, links to some documents from CLSI that talks about updating breakpoints as well. Kind of very helpful to it. Like susceptibility, FDA, if you just touch that link, it'll take you to the FDA site for where the FDA breakpoints are. And we'll talk about this a little more in detail. And again, a link to the M100 with the CLSI breakpoints. And then references, again, some more documentation. So now to get to the CLSI breakpoint toolkit, you just go to clsi.org, and right at the front page, there's a section that says the CLSI breakpoint toolkit. And then it'll show you all the videos for each section, and at the very bottom, there'll be a button to click to download the entire toolkit. So you would just click there, and the toolkit is in a zip file, so they're compressed. So you have to open that file. Then when you open that file, depending upon the computer system you're using, it'll look something like this. There'll be all these, the items with, begins with a $sign in front. Those aren't any file to be opened. There's just something that comes along. It's the one below those that have all the sections to the breakpoint toolkit, all the spreadsheets that you're going to use when you're doing your breakpoint updates are there, as well as a lot of detailed instructions on how to do this process. So I'm going to start with A and B, and again, these are to get your situation determined about where you're at and what you need to do to determine which breakpoints you need to update. And A and B, this is part of the presentation that I put together. So the two CAP requirements that really focus us in are relatively new ones, just updated last year, MIC 11380, antimicrobial susceptibility test interpretive criteria. So this says for your AST testing, you have to have written criteria for determining interpretation of your MICs or disk diffusion as what is SI and R, and that these are reviewed annually. So they want something written down on one sheet, spreadsheet, about what your drugs are, antibiotics, interpretive criteria, and as I've circled in red there, and then another thing is to review these annually. And this, turns into a very big job. So we're a medium-sized laboratory, and so we've got about, on our sheet, we've got about 100 antibiotic and drug combinations on there. So this really took us a long time. I mean, we started in May, and we finished it in August, I think, people chipping away at it and everything. So this really took us a long time to put together. But now it's together, hopefully the annual review, we have pretty much everything. We have everything on there now. So it'll be a little easier as we go forward. But the initial effort to put this document together to meet this requirement, boy, it really took a while. And then so the other one, 11385, this deals with when new breakpoints are published, either at CLSI or the FDA. It mentions that you have, starting January 1st of 2024, you have 3 years to update and to comply with those new breakpoints. So this is where this toolkit can really be helpful. Like I say, if you use the sheets that come with it, that'll do all the calculations, it really helps streamline things as you go about those updates. And this is just the rest of this. So breakpoints you can use, you know, the well-known ones are the CLSI breakpoints. This is the M100 for this year. You'll be using the 34th edition next year for those breakpoints. And then they mention the FDA breakpoints. See, these are certainly the two most common. Another one that's mentioned is the European, the UCAS breakpoints. There also would be acceptable. So this is where you go when you go to the FDA site to look for what they call the STIC breakpoints for susceptibility test interpretive criteria. Once you get there, you get to this page, you would just select antimicrobial susceptibility test interpretive criteria. It would take you to this page. And then you would just scroll down until you come to your antibiotic of interest, and you would just select on it, and then it would give you the information for the FDA breakpoints for that particular antibiotic and various bacteria and organism groups. So let's start getting ready and getting our breakpoints together that we have. So we'll start with the Part A, the breakpoints in use. And in the kit, you have a spreadsheet, and the spreadsheet comes with directions on how to use it that are shown here, and how to start filling it in. And the first thing they say is talk to your IT people to see what breakpoints you're using. And I'm thinking, now how hard can this be, to figure out? So I go over to my machine, and I don't have a clue on, how to find, where those breakpoints are or anything. So in addition to talking to your IT people, which were helpful, because they told me, Ray, everything that comes across there is going to get reanalyzed by what we have in our laboratory information system. So I got a set of breakpoints in my instruments, and I got a set of breakpoints that are actually in my LIS that are making the final interpretation. But my LIS couldn't tell me everything, those folks, because I wanted to say, well, what all went over? Does it just the ones we report go across, or do all of them go across? So they said they couldn't help me with that, but they could give me a spreadsheet that showed me all the interpretive criteria that it's using. So they were helpful, but I needed to go to the vendors for my instruments to get more information on how to figure out what breakpoints the instrument was using. And it turns out with the Vitek 2, that was pretty straightforward. They told me where to go, and then I could find them. But then we also use some microscan panels and just a reader. It's called an AutoScan 4. And so, I couldn't see any way in the instrument to find the breakpoint, so I contacted our rep, and they sent me a document that said, these are the breakpoints that this instrument is using. And those breakpoints were from 2019. So that document was years old, and so that's the ones that's using. So obviously I needed to have our LIS to make other interpretations, because on many of the interpretive criteria, that AutoScan 4 is way behind. So they were very helpful. And for the breakpoints in use spreadsheet, as I had mentioned, they give you directions, but they also give you some examples on how to put the sheet together. So this is just some data that I put in here. And you've got your various headings here. So we'll do amikacin here. I don't know if I can. We've got amikacin. I don't know. Can you see that?
Mouse has to be on the top screen. So go to your right on your screen until the mouse appears on the other one.
Over here? Which?
It should just, let's see.
Which?
You're in this view. Let's give you a pointer first of all.
Let's give me a pointer. Because yeah. Okay, that's yep, that'll be good. All right, so we're going to do amikacin for the Enterobacter aeles, and I've got two cards. I use a Vitek card and a microscan card. Okay. Now here's something to this chart that I did. I added a column for this test system reportable dilutions. As of when I looked last week on the toolkit, it didn't have this column. But in the video, they talked about this column for breakpoints in use part A to put in what your reportable dilutions are. Because then it makes it a quick spot where you can look and see, well, those new breakpoints aren't going to work at all with what I've got on this card right now. So I put that column in there. And then, as I mentioned, figured out what my interpretive criteria they were using. And it's 16, 32, and 64 for susceptible, intermediate, and resistance. And I just put a few things that you could use, instrument, LIS, because what it turns out that I found out, all of mine are from the instrument. So now it asks, do your breakpoints match the M100, or do they match the FDA? And this is where we're going to just jump ahead a little bit here, where the Part B comes in. This spreadsheet is just a sheet that's got the FDA and the CLSI breakpoints on it in a very easy format where you can just line them up and look at both of them right there to see where you're at. So what you do is you can take this sheet with the other sheet, sheet B with sheet A, to help you finish filling out sheet A. So here's what it looks like here, part B. So we're doing amikacin, Enterobacter aeles. So it says the CLSI breakpoints are 4, 8, and 16 now, and the FDA breakpoints are 632, 16, 32, and 64. So in the toolkit, they do mention that CLSI would like you to use the CLSI interpretive criteria. But remember, you can use either one. So, 16, 32, 64, or 4, 8, and 16. So if we go back, so here, my breakpoints don't match the M100 because I'm 16, 32, and 64, but they do match the FDA breakpoints. But I want to, follow CLSI, be a little more current. So I'm going to need to update my breakpoints for amikacin and Enterobacter aeles. And then another thing that catches my eye is that, it's 4, 8, and 16, and my microscan panel is 16 to 32. So I guess I won't do much any more microscan using this panel to test the Enterobacter aeles with amikacin, since it doesn't have the dilutions that go low enough. So these Part A and Part B spreadsheets really work together to help you fill out this form to determine what breakpoints you use. Like I said, we're just a moderate-sized lab, and it's about 100 organism antibiotic combinations that were required to fill this sheet out. And then one last thing here is that with this sheet B, the Part B with the CLSI and the FDA breakpoints on it, the FDA can update a breakpoint anytime throughout the year. CLSI characteristically does it once a year when the M100 comes out. I know a few years ago they did it twice in 1 year for something. So if you've seen the talk that Tom and I are giving, you're all excited, you're all gung-ho, you're going to run back to your lab and you're going to, man, I'm going to get on this, crunch this stuff right out of here. You might want to check the FDA site to see if there's any updates to the breakpoint in there, because this sheet, as it says here, is current for the FDA breakpoints to May 22nd. So has the FDA changed anything between now and May 22nd on their side? So what you can do is you can go back to the FDA site shown here where we were before, But now we want to click on Notices of Updates. So we would select that. And then it would give you this list of updates, and they're by drug. So they're alphabetized, starting with amikacin and then going on down. So they're not by date. So you can't look to see, are there any past May 22nd, 2023? They're not in order, so they're in alphabetical order. So you have to look for them all. So I found one here that was May 25th about a couple of drug combination that, is not very commonly used. But what I don't show here is I found one for June of 2023 for the Enterobacterales and cefepime that the FDA had made an update. Prior to June on the FDA site for cefepime and the Enterobacterales, they had susceptible, intermediate, and resistant. CLSI had susceptible, dose-dependent, and resistant. And so the FDA updated theirs in June of this year to say susceptible, dose-dependent as well. So here's a teaser, though, maybe then. So they switched to susceptible, dose-dependent. The MIC is still the same for that. Do we need to do a verification or a validation for that? God, I hope not. All right, so that, now you know what breakpoints you're using, what you have, and how to get there. And so now I'm going to turn it over to Dr. Novicki to finish it out, going over the other parts.
Thank you, Ray. All right, so now Dr. Podzorski has explained to us how you identify which breakpoints you have that are not in concordance with FDA breakpoints and ones you're going to need to verify or validate. We're going to talk about now a couple different things, section C and D. C is the actual, we're going to go through this quickly, it's just a documentation form. So, remember, if you get the toolkit and you click on C, you're going to open up a form. It's pretty self-explanatory. We'll take a look at it. And then D is actually a resource that FDA and CDC have provided for validation strains. So I have a clicker. This one? Yeah. Yep, C, okay. All right, so as I've already explained, when you have your, you've downloaded your toolkit and you've unzipped it, you click on C, and you're going to get this form. This is the whole form, and it's it's fairly explanatory, verification, validation. You put all your details in here. You're going to put in your values here of those. So now you've identified which breakpoints you need to verify or validate. And you're going to list that here. It's just documenting for use. If you have more sets you need to use, obviously you can just create an Excel spreadsheet and add to it. More information about accuracy and precision and so on. And if we advance, we go to, now we're going to actually take a look at sections of that form I just showed you in total. And again, it's just informational here in the top part. An expansion, this is where you're going to list your current breakpoints, the breakpoints you're moving to, and the antimicrobials, the source, so on and so forth. Now, as we point out, and this was done by our colleague C&D, by Dr. Munson. I want to give him attribution. You may not have to fill out the old breakpoint section, and why is that? Well, because this is a living document that's going to be used as we need to keep it update. We'll probably do it annually. You may be adding drugs, okay? And so, for instance, he used meropenem vaborbactam. Well, in that case, if you haven't used it before, you won't have any existing breakpoints you're using. So you'll just have to decide again, but using the same resources. Are you going to use CLSI? You'll need to validate it. Are you going to use the FDA from the STIC database? Then you do a verification. Again, just more information that you fill out on this form. It's just how you're going to document. Frankly, if I had set this toolkit up, I would have put this towards the end. It's a little bit out of order, but you know, we can show it you know, now as good as any time. Two things, you know, we're going to talk about the reproducibility or the precision and the accuracy, the data. And this is where you're going to have summary of your findings. Okay, we're going to talk about this a little bit more. I'm just going to skip over this when I get to my section. Okay, so now, so we have these breakpoints that we need to validate or verify. Okay, and we have to say, we have to have acceptance criteria. And when you're talking about doing verifications of susceptibility testing, you can have essential agreement, which is that the MIC values are in agreement, or the categorical agreement, which is, do they agree S, I, or R? Generally, when we're doing these studies, we'll look at the categorical agreement first. I'm going to point something out, and I didn't grab it, but I'm going to show it to you. And it's this CLSI document that, you know, besides M100 and M2 and M7, is this M52? M52, and it's called Verification of Commercial Microbial Identification and Antimicrobial Susceptibility Test Systems. Take a breath. All right, that's the long one. And it's great because, you know, as we know, microbiology is different from chemistry, it's different from hematology. You know, sometimes we have to make these things kind of work for the biological systems that we're doing for ID and susceptibility. This is a great document. It's for verifying, you know, so you have an FDA cleared instrument of ITEC, you know, a microscan, and you haven't modified, you haven't changed anything, then we do the verification. This tells you how to do it. But in the back, there's actually a section of how to verify alternate breakpoints. And so, you know, a lot of the information we're giving you now is spelled out in more detail in this document. And I highly recommend it. And so they're going to talk about these, you know, categorical agreement versus essential agreement and so on and so forth. You can set, there's no rule about what you need to set for your acceptance criteria, but certainly this document here and you know, the toolkit, you know, we recommend, you know, an overall agreement. After you've done your study, you've tested 15 isolates, you've tested 30 isolates, you've done the calculations, which I'm going to show you how to do later. You want to have an overall agreement of at least 90%. That's a good target. And then we look at actual different types of error rates. And so there's several types. There's very major error, very major because these are errors where a resistant organism, truly resistant, is called susceptible. Very major because you can treat the patient with a drug that isn't going to work. Similarly, a major error is an error where the organism is susceptible, but it is measured as resistant. Not as bad, because you're not treating a patient with a drug that won't work, but you're ruling out a class of drug that could be helpful. And then finally, there's the minor errors, which are a result that involves an intermediate and a susceptible, and an intermediate or a resistant. Okay. And so those criteria generally are less than 3 for very major and major errors each. And then minor errors, it's left more flexibility. It's up to your laboratory director. And of course, your laboratory director, as with any verification or validation in your laboratory, it should follow the protocols of your laboratory, and your director should sign off on those. And so for minor errors, we often accept 10%. And again, there are exceptions. You know, these are not hard and fast rules. Certainly, you know, you don't want to stretch the boundaries too far, but a lot of it is talked about in this document. And I don't have time, but I can talk about it after, as like some exceptions that you might make to these, you know, if you don't quite hit these numbers. And then reproducibility, so that is, you know, intra-run reproducibility, or precision is the term we tend to use, 95% agreement. Okay, this is how the numbers are calculated, and I think basically very major errors are, so for truly resistant strains that test as susceptible, that number, divided by the total number of resistant times 100. Similarly, major errors are truly susceptible strains that measure as resistant times 100. And then minor errors are total number of minor errors divided by total number tested. And reproducibility is just the number of correct results divided by the total tested times 100. Okay. One other thing I'm going to talk about a little bit, I'm not going to spend much time on here, but it is on that form, is, so let's say you don't quite make the acceptance criteria. Okay. There are some things that you can look at to resolve those discrepancies. I'll talk about a few examples a little bit in my part, but those are recorded here too, because discrepant resolution, if your director agrees that maybe your reference result wasn't right, or there was some exception, you can update your results to actually now match your acceptance criteria, and you should record that on this form as well. Okay, this is in my section, so we're going to just go over that. I apologize, this was a group effort, and there's some replication here, duplication. And then in this last section is again, you're summarizing your results. And again, if you've done more verifications or you've done more drug-bug combinations, you can add to it with a Excel spreadsheet. Okay. Make sure your directors sign off on it. Okay. As an inspector, we like to see that. Now, here's an important part. Say, well, where do I get these isolates? Okay, most of us do not have AST and and ID reference libraries ready to roll with reference quality data. Well, the CDC and the FDA have gotten together and produced this AR Bank Breakpoint Implementation Tool bit isolate sets, and there's quite a few of them. If you just Google that, CDC, even just AR Bank bit isolate sets, you will find the website, and they have many different sets. So for verifying your MALDI-TOF, but they do have several for susceptibility testing. And so now we're going to go. If you open up your toolkit, D. Click on D, and you open that file, and this is what opens. And it's like, well, gee, what's this? It's one page. But this is really the keys to the kingdom for getting your isolates. So if we walk through it, we can take a look and say, okay, there's 4 of them. They each focus on specific bacterial groups, specific drugs, and then the drugs that are focused upon in this group, and the breakpoints. And so, and these are links. So when you open it up on your computer, you can click it, and it will open. So let's say now we're gonna, use the Harry Potter World of Magic, and we're gonna, tap 3 times, and voila, this is gonna open. And so what we're seeing here is each strain in that set, and they're just numbered sequentially. Number 1 is E. coli, and the resistance mechanisms that are there. Importantly, it has a KPC, and you can now, if we click on this or this, and you're going to see this, and here is all the susceptibility test information on that strain in terms of MICs and interpretation. Now, if we were doing this, without another part of this kit, and a very important part, this would be your reference data. So when you're setting up your verification or validation, these are the expected results. And we'll come back to that. But to get back, so these panels, there's about 30 to 34, between 30 to 34 isolates. There's susceptible, intermediate, resistant. Eric wrote this up. He feels there might be a little short on susceptible isolates. You may have to supplement. That's a little bit beyond the scope of this talk. But you would have to, in short, pick some isolates that you have. You might send it off to your reference laboratory for reference lab testing. Not to plug them, but Mayo Medical Labs does agar dilution, which is a reference method, so you could get your data there, your comparative data. Again, this M52 is a good resource for doing this type of study. Okay. Now, it's a little, I should go back here. Let's see, what do? Up, previous. So, no, not that. At the top of this page, if I remember correctly, you are going to see this. So how do you get these strains? Okay. Basically, you could certainly, AR isolate bank and navigate, find this page. The important point is, it's like you're putting these into a cart. You don't have to pay for them, okay? They're no charge, but it's like you have to put it in a cart and check out. Before you check out, you have to have an account. We all know how to do this, right? Amazon.com. Whatever. So you log in, you put it in your cart, and then you go to checkout. And this would be just a little bit more detail. You want to choose your panel. And again, like I said, there's many panels, but you want to pick one of those that is in part D of the toolkit. And then there's a process. Now, there's a couple things that you need to provide to them before they will send you these isolates. And so, when you set up your account, you get the mailing information and, all that. But basically, the first thing is they're going to wait to get documents from you. And I'll show you those in a moment. Then they verify that they're correct, order, they put the whole order together. It's just like Amazon Fulfillment Center, not as fast. And then they finally get shipped and they're delivered. But what you need to provide are a couple things. It's a letter of agreement for sharing. Basically, you're saying, I'm just using this for my own use. I'm not going to share it. I'm not going to sell it. I'm not going to redistribute it. You need to have your director sign it. So that'll be printed off, and you're going to submit that to them. And the other one is a biosafety compliance. And again, it's saying you agree that you are going to handle this in a correct manner. You sign that. And these are this and the other document, the sharing agreement, these are the things that they will be waiting for before they send you your isolates. Okay, so now, so let's think about what we just talked about, these last two sections. It's basically, section C is the form that you're going to fill out. It's your documentation, what you've done, what your results were, how you resolve discrepancies. That's what you're going to hand to your director. They're going to sign it, and then you put it in your binder. And when the inspector comes and they start asking you about this, that's what you're going to show them. And then part D is using the isolate, AR isolate bank to get your bank of isolates to actually verify or validate those breakpoints that Dr. Podzorski showed us how to identify. that need verification validation. Okay, now the magic begins. And we want to take a moment of silence for Alan Rickman. He was wonderful. He was a great Snape. He was a great actor. Unfortunately, he passed away. If you haven't seen other movies with him in it, watch him. He was a perfect Snape. Anyway, we are now going to see how he put this pieces together. Now, again, I'm not going to spend a lot of time on Part E because it's instructions for Part F. Okay, and this is basically the table of contents. But this is where you're going to find out accuracy, precision, more information on that. And you know, it's just look at it and work through it. We're going to get to the important part now. F is how we put the information together. And so that's this F is actually, it's an Excel file. And it's a very complicated one, although not for us to use, but in the way it was built, it has a lot of calculations in it. And there's multiple tabs. First of all is breakpoint overview, tells you what you got, it's just text. The next tab is actually a summary, and this is really cool because it's linked to the individual accuracy and precision tabs and keeps track of your results as you input data. And so you can just go to this summary and see, where am I at with this validation study? Where am I at with this verification study? And there's, remember, the basis of your verification validation is accuracy and precision. So what they've done with this bit, this tool, is they've created accuracy and precision tabs that are pre-populated with all the strains in each of those 4 AR bacterial, the sets that I just got done talking about. So how does that work? It'll make more sense when I show it to you. Now, in those tabs, there's these formula that perform the calculations and they summarize data. And it's really nice because you can sort, you can filter, you can drill down, and this would be helpful to you. And hopefully you know enough. You've used Excel spreadsheets. You know how to use filtering. If not, investigate it. Ask some of the younger folks in your lab. There's always someone who's competent. I'm pretty dumb about it myself. I'm always asking. Because by filtering, you can kind of drill down. So when you're done, you look at that summary and say, oh, you know what? I was off here. Well, let's find out, go back to those individual tables and do your filtering to find where your problem is, and then that's where your discrepant resolution might start. Now, it is locked. I don't believe it has a password. It might, but you don't want to unlock it. It's only locked except for where you input your data, because you don't want to mess up the calculations. So don't worry, you can't mess things up with accidental keystrokes. One important thing is when you click it open, it's going to say, well, okay, yeah, I'll say it now. When you open it, it's going to say, do you want to run a macro? And you don't really have to for this thing to work its magic. The macro is only, I don't know why they did it like this, but at the top of each of these columns is a clear, clear contents. And it'll just, in case you made a mistake, you got to start over, you hit it, you clear it. And that's the only macro. So what I'm saying is, that's fine. You don't need to enable macros. You can clear those columns manually, but no worries. You don't need to run those macros for the table to run. The other important thing is that these are MIC only. So for the labs that are doing Kirby Bowers, this table that I'm talking about now, Part F, it's not going to work for you. Part G is basically a blank version. Part G is the last part of the tool it's a blank version of F. But you will have to use the calculations. So in those isolates, remember when I showed you, let's see. No. Come on. It's not fast enough, Erin. Can't keep up with me here. Come on. Okay. So you remember I said, when you go to this isolate set, and then you have all these different isolates, you click on the isolate information and you click next. You'll see that there is not only MIC, but interpretation. And remember, when we're doing the analyses, we're usually looking at categorical agreement, SIR. So if you have Kirby-Bauer, you can still use these banks, but you'll have to manually copy this SIR information into the blank table in G, and then use those calculations to calculate very major error, minor error. You'll have to do the math yourself. And again, if you've got a Kirby-Bauer, and I will say, after this, if you guys got any questions, feel free to email me, or call me, and I'd be happy to talk about it. But it's also, how to do these things manually is in there. But the point is that if you're doing Kirby-Bauer, you can still use these banks, but you just have to do it manually. The concept is the same. Okay. Now, this is where it is really. It's the magic of Excel, if I have to be honest. Excel is so powerful, and most of us just don't even, we just scratch the surface of it. And this uses a little bit of that magic. So this, okay, there's a lot of information here. What I did is I took a screenshot of when you click on F and you open that Excel, you're going to see the tabs that I described. Now, I can't click on it, but Breakpoint Overview, it's just text-based, kind of tells you, gives you the lay of the land. The summary, I'll show you that in a moment. And then here is those tabs for bit 1 accuracy, bit 1 precision. So these are those isolate banks, and you can see that these are those isolates and how they might apply to the drugs that you're testing and the breakpoints that you're testing. This is where I said I would come back because they have recommended in green the strains that you might consider for your precision testing. And remember, you're going to get these, okay? One other thing that I should have showed you too, but there's nice information when you click on, so when you navigate, you're going to buy your isolate sets. There's different tabs, and one of them is propagation. So how to store, how to passage them, as you're doing your studies. This is a good example here. This is where you put your information in. Now, there's a couple different ways. Well, actually, you remember when you get an MIC with our instruments, we either get a discrete number or a greater than equal or less than or equal to. So in this column here, one can input numbers, whole numbers. And optionally, if it is a greater than equal to, or greater than, or less than equal to, or less than, you can choose that here. You don't have to put anything in here if it's a discrete number, 8, and resistant. And here it's going to give you, and this is where the calculation comes in. It says, yes, you are essential agreement, because over here, you can see the reference value is 8, and the MIC is 8. Down here is actual summarizing for this table. So again, you've got your essential agreement, MIC to MIC, categorical, interp to interp, and then your error rates and your ends. And this is what actually then will get aggregated in the summary table. Okay, let's take a look at this a little bit more. And here's some examples of what you can get. So let's take this one here. It's isolate number 1. We have a value of 8, resistant. It matches. We're in agreement. We're in agreement. All good. Here's an example where you put in one of these signs, greater than or less than. Again, 8, R, yes, yes. It likes it. So here are examples where everything is copacetic, okay? Here's an example, and I just punched these numbers in just to get what I wanted to see. Hopefully, we'll be very much closer than some of these examples. So here's where, the reference value is 8, which interpreted as resistant. I put in 2, it's interpreted as S. It says, it doesn't match, either with essential or categorical, and it's a very major error. See, this is where these calculations come in and does so much of the work for you. Now here's another example where the essential agreement matches, but the categorical agreement doesn't. And I don't have a lot of time to go into this, but if you think about what's going on here is, we're not changing how the instrument determines MICs. That's been validated by the instrument manufacturer. You're changing how the instrument interprets those numbers. And if you think about it, by definition, as you shift a breakpoint, and they tend to be fairly small, 1 or 2 dilutions, is if you have a strain that has an MIC that's kind of in that range that changed, you may very well get a minor error, and it'd be because it was interpreted as an intermediate, and now it's interpreted as an R, or it was interpreted as an S, and now it's an intermediate, and that's a possibility, and so so here. It's agreement. It's not exact, but it's -1. It's 1 dilution difference. That's okay, but the interpretation changed, and that's okay. That's and that's why when I said earlier is like these are your minor errors. You're probably going to see this minor errors. You tend to we pick 10% minor errors overall. In our laboratory, you're going to have some of these. Now it's a fact of life. You want to make sure you don't have a bazillion of them because you want to make sure something hasn't happened with your test system. But we've done a lot of these in the lab, and you accept that there's going to be some change around that breakpoint. And that's when you kind of have to start drilling down as well. Did my, did the MIC reporting change, or did something happen in the system? Again, M52 is great helping you work through this. Here's another example where you put it, you can get all kinds of strange numbers, The MIC really jumps up. Well, the essential agreement doesn't work, but your categorical agreement is still an agreement because it's all resistant, right? So, my point is that you're going to want to look at these numbers, and if we go to the next. Okay, well, we'll come back to the summary. The precision is just that, you're repeating testing. And you just want to make sure you're getting the same result multiple times, all right? And so remember, so each of these bit sets has an accuracy tab and a precision tab. This is the precision tab. And again, you can only populate certain sections, and then it does your calculations for you. So in this case here, you had an R, and then you did the test again, you had an S, and then you did the test again, S, all the same isolate. So you had 2 out of 3. You'd see, and it detects that, okay? But then, when you fold it all together, you say, okay, well, I tested 13, and I only got an 87% concordance. But, you might look at that and say, it was 1 dilution different. And that's acceptable. Again, M52 talks about this. So I correct it and I say, okay, well, actually, if I throw that one out, I'm going to get 14 out of 15. And now I got a lot better result. All right. Here's the summary tab. So, if you look in the top here, you're going to see these different rows of your data. So like for instance, in bit set 1, Enterobacteriales, Cephazolin, you tested 15 strains or so on and so forth. These columns will get populated with your result. And if you scroll down, you're going to just start seeing, now these are not populated because I didn't put numbers in, on the parent pages. But basically the summary tab has all of your data. This is what you're going to use when you actually write this study up and say, yes, I'm compliant, or no, I wasn't. I have to do more work. Okay. So now there's a lot of information there. Where was I? Oh yeah. So let's say you get done with this, and you haven't met your target. Your minimum. You went over your 3% very major error, or your 3% very major, or major very major, or your 10% minor errors. You're gonna say, well, what went wrong? So that's where you start needing to drill down into the data. Was it random? I mean, stuff happens. So you might do 3 more, retest times 3. Give it another chance. You might ask, did your working strain? This is a lot like if you have a QC failure in, just on your susceptibility testing, in your daily or your weekly testing. You kind of go through the same stuff. Did my working strain go bad? Did I not pass it enough? Did I not store it correctly? Is it an old strain? Strains, if you're subbing them a lot, they can lose plasmids, resistance plasmids and stuff. Maybe the strain is just contaminated or bad. If you're wondering about that strain, you can certainly send it off. You can do Kirby-Bauer, to verify, yes, it's giving me the results I expect. You can throw it out. Sometimes, if you see evidence of just this strain isn't working like I think it should be, just throw out that piece of data. You have other strains. Use that data. You can certainly consider that. Or did it get contaminated? Look at the subplate. Is it mixed? Okay. I think in the end, you can certainly consider consulting the vendor and asking them for help. A lot of times, I know BMRU, our field application specialist, Tina Jager, is very helpful, on this kind of stuff. She's a microbiologist, so consult your vendor if you're just having trouble with something. And then if you still don't get an answer, call Dr. Ray Podzorski. You know, again, this is not, you know, this isn't chemistry. You know, it's a biological system. You know, so I've taken this out of M52. Again, you know, and I alluded to this a moment ago, is like, you know, if you're seeing small variations, you know, that's why, you know, don't get too hung up on minor errors. Yeah, you shouldn't have, you know, 40 or 50% minor errors. Or, you know, it's like, let's say your minor errors are, you know, within the 10%, but all of those were with one bug or one drug. You know, but in general, you know, there is more room for a 1-2-fold dilution plus or minus. And that's kind of like, you know, I talk about, you know, discrepant resolution is you might go back and say, hey, you know what, you know, 3 of these 5, it was one dilution, you know, and it's all over different strains, and it's like, it was random. Again, you gotta, you know, your director has to agree that you're gonna, you know, that's acceptable, but it's certainly worth consideration. One other thing that I will say, and again, this is up to your director, I think, is, you know, if you did your instrument, if it's, you know, if you verified it relatively recently, you know, you got it. You did precision studies. So when you're changing these, you may consider not doing precision. Now, that's, you know, your director has to agree on that. You know, and I've done that. You know, and I'm a cap inspector, and, you know, I'll say, you know, because like when we bought our instrument on, and then we updated breakpoints 6-8 months later. So, well, hey, you know, we just did the precision. Refer back to that. Now, if you haven't done your precision studies, you know, if you have the instrument for 5 years, you know, 4 or 5 years, then I would say do the precision. It's not that much more work. Again, that's a decision that your director. I'm not advising you do it or not. Just something you may consider if it was done recently. Just, you know, consider the breakpoint change part of the whole onboarding of the instrument. Okay, this is the last part. This is Megan Sell, another lab tag member. And, you know, again, I've already talked about G. If you click on it, it's a blank Excel spreadsheet. You just, if you have to do manual, you know, you're not using the bit sets, you can't use that table, that nice table that does all the calculations. You're going to have to do it manually. You would do it in G. But, you know, the information is there if you're using the isolate sets, as I showed you, you know, for each of those isolates, if it was SIR. And you would just have to do the calculations manually. This is an example of it. And that's really it. You know, now you're going to go back to that sheet and you know, in your summary sheet, I think it was part C, I think, and complete it. So you know, it's a lot of information. You know, I hope this helped. And if you have any questions for myself or Dr. Podzorski, feel free.
All right. Don, you want to come up, or you want me to run over?
So what you're saying, the problem we're having is we use a Vitek. The FDA range for resistance is greater than 128. On the CLSI, it's greater than 32. So even in those AR bank isolates, there is nothing challenging the middle ranges. There's nothing, they're all either less than 4, because I've looked it up, or greater than 128. But we don't really care about that as long as, because they're saying that's resistant, as long as we get a resistant. I mean, that's my struggle, because I have nothing to challenge that greater than 32.
Yeah. So your okay. So your question. So you've got. Tell me again.
Okay.
You had the braid, so your instrument is 120, greater than,
Greater than 128 for the FTA.
that's in there now?
For
Or that's the,
pip-tazo, for pip-tazo,
Yeah,
that's in
okay.
there now.
yeah.
And it's less than 16
Mm-hmm.
for sensitive. So the new ranges are like less than 8
Mm-hmm.
and greater than 32.
Mm-hmm.
And then it's the SDD on the new, and there's no real intermediate. It's kind of that dosage kind of.
Yeah,
And so when I looked at the AR available isolate sets, I'm looking for a pip-tazo somewhere on one of the organisms for the gram negatives that's like a 32 or a 16, and there isn't any. They're less than 4 or greater than 128, which is what my instrument gets right now all the time anyway. And so
Yeah.
I'm looking at this going, but my take is that you said as long as the interpretation matches, I can, even though the MIC on these AR bank ones for resistant is greater than 128, I'm going to get a resistant
Yeah.
too, but then I can switch down to 32.
Yeah.
I mean, I'm just really confused
Yeah,
about this.
and Ray, I'd like to hear your opinion on this too. So, my feeling is that in general, categorical agreement is considered acceptable. When I think about this, again, the instrument is well validated by the manufacturer. It can produce the correct MICs. It's just a matter of how you interpret it. You have to do it, but to me it's not like, okay, I've changed a molecular test. I've changed an amplification parameter or something like that. Yeah, I'm going to be worried about those values that are being generated. I have to believe that the FDA and the CDC put those together. It's for a reason, and they didn't include. Now you could be cynical and say, well, you know what? Where these things are in the middle, and hey, we didn't put in any middle values because you're going to see errors. That's the cynical me. But I would stand by and say, if the categorical agreement, it's acceptable. That's the important thing. You didn't change how it generates that MIC, and you're not saying, I'm not revalidating. The MIC is the MIC. Because what you're doing is, in a way, you're proving clinically that this instrument is going to give the right result with a given MIC and what's expected with those new breakpoints. Now, you can certainly add to the bank. It's not doing that is not something that's going to be simple. Ray, what do you think?
I agree with you on the categorical, and if the process, this toolkit for what you're looking at, Dawn, will tell you which panel to use from them, and you're using that panel. Yeah, but you're feeling a little squeamish about, I'm not. This middle range is really what I want to show that I can call, and there aren't any organisms to do that. And I think you run the panel, and any inspector is going to be fine with that, and look, and because the categorical agreement was correct. But as I mentioned, our colleague Dr. Eric Munson has a lot of isolates with a lot of different MICs that he's accumulated over the years. So, as I mentioned, I would contact him and see if he has any in that range that you're interested in, and have him send you a couple of those. And then, it'll be interesting to see what you find. And I think he uses the Phoenix. Do you know, Tom, what Eric uses?
That sounds right.
Yeah, I think he uses the Phoenix. So it's going to be a little different probably than the instrument you're using. But then that's something that then you would have them right there. So if he doesn't have them, then, they're hard to run across and hard to find, because most of them are usually all the way one way or all the way the other.
Ray, has he tested those with the reference method, or are those Phoenix values?
Again, those are Phoenix values,
Yeah,
but at least it's a different laboratory, as
Yeah.
they say that you can have another laboratory test them.
Yeah.
Yeah.
And that's covered in M52.
Yeah.
Different approaches. Yeah.
Yeah, I'm not that squeamish. We can get into an argument if this is even something that we should be doing in the first place on an FDA-cleared panel for that range on an FDA-cleared instrument. So.
Yeah. And one other thought is we take a pragmatic look at it. We say, okay, we've been changing things in the instrument. We want to make sure we haven't botched something up. We want to make sure that it's showing up correctly in the EMR. And that's as much of a part of the validation as everything else. So what we'll do is when we make these breakpoint changes, we tell the techs, we say, hey, you know what, for the next few weeks or a month is watch how these things are coming across. And those are part of our breakpoint validation changes. Because, to me, that's as big a concern, as messing up some global rule, or something is tripping differently, and we see this, and so to me that's an important part of changing breakpoints. The instrument is, the MICs are right, is to make sure is that what you've punched in is giving you what you want, what you're expecting with those new breakpoints.
Second question, not all of us are CAP accredited. For those that are JACO accredited, I haven't heard that they're following the same guidelines.
Well,
I
lucky
don't
you.
know. And I was recently told by a bioMérieux rep that for us, we have the option to keep with the FDA as opposed to going with the CLSI. So that even muddies the waters more. So
I don't know. Anybody can speak. My presumption is that this is coming down from CLIA and CMS.
So this
Or
was
is this CAP-driven?
this was brought up during one of our other meetings as well. Some really interesting discussion points on it. Right now, JACO isn't requiring this. However, this first started from on ClinMicroNet discussion board with lab directors. A survey went out asking how many people were actually following the most up-to-date breakpoints, because it's important for patient care, because it's important to treat them appropriately based on the information that we have available. And a surprisingly large number of laboratories were not using current breakpoints because it is hard, it is challenging, they didn't know where to start. And so that's why these kits got put together, is to help that, and why CAP really put that push through to make this a CAP checklist item. And from what we've heard, JACO might be implementing after they see how CAP does. So if this gets really successful with CAP, then JACO might also implement this down the road, but for right now they won't. But the important thing is why we're doing it, is to really treat our patients as best we can.
Exactly. Yeah.
Thank you.
One little thing. You're talking about this specific organism combination, and you want, you're looking for the break point of 16 to 32. Where did Lacey get it? And do they have it?
Well, so the if I understand your question is, how do they, for those isolates, how do they know that the MIC is 16? So there are reference susceptibility methods, and the reference that gets used very often is broth microdilution using frozen panels. That's a very popular one. So CLSI considers microbroth dilution, agar dilution as being reference methods. Yeah. So
Asking, where did they get the organism that give them their value?
Oh, they just look around for
Yes,
them
but
and collect them.
would they be willing to share?
So Eric Munson is very willing to share the isolates he has. You mentioned that at both meetings. So anybody who's having issues with isolates, please do contact him first, okay? And let's start there. We have a wonderful listserv. You know, we can always use that listserv, and you can put out a message. I am looking for an isolate in this range. Does anybody have one? If we have something at the state lab, we're happy to share too. We can use each other. That's the beauty of our clinical lab network, is we work together on these things, and hopefully we can get these problems resolved if we have them. For the most part, I think, you know, we're just trying to help each other. That's the whole point of this whole presentation. There are different opinions about what should be done, how we can do it, but hopefully we provided information from a nice tool that they did put together to help laboratories to do this. And I really don't want to keep people anymore. I want to thank our speakers today that did this. Thank you, Ray, and thank you, Tom, for putting this, you know, working with us.
Thanks.
That being said, I do want to give the PACE code numbers out, so everybody get those purple sheets out, and I'm going to read those to you so that you can get your PACE credit at the end of the day. And then in the afternoon, the session code is 3762. 3762. So make sure you enter those when you go in to claim your PACE credit.